So today we are going into the neurobiology of nicotine addiction. So what Dr. Aruna did with us is that she brought in nicotine. She gave us the history of nicotine. She told us about, she gave us an overview of things, and in all different aspects. Even talked about the new products, talked about what are the harms, what really happens. She talked about some part. She touched bits and pieces on the entire course. So today we are going to do in depth about the neurobiology of nicotine addiction. It's an important aspect because that's when we understand what is really going on there.
So just if I can say few words,
Yes.
ma'am.
Yes,
Reena,
please.
yeah.
Yes, please.
So what ma'am is what we need to understand. What ma'am is going to talk about right now. See, we are seeing patients every day. Every one of us seeing tobacco patients, right? And my question here is tobacco a habit or a disease? We are all dealing with disease. We are doctors, we deal with disease, right? So disease का क्या होता है? अगर हम लोग first year, second year, third year, fourth year of our MBBS or BDS, if we go to the first year, we are learning the normal, right? What are the normal things? Second year and third year, what we learn is the pathology, the abnormal things. What is the abnormality? And the finally what we learn, if this is a normal, this is the pathology. Now how to deal with the pathology, right? That is the medicine part, the surgical part. That is what we learn in the clinical aspects, right? So last time we learned what are the normal ways, what are the normal things available in the market, how they are affecting and what is happening, right? But then if we are talking it is a disease, we as a doctor, if we are approaching it as disease, so we need to understand the pathology of the disease. What is happening, the pathology, the physiology, what is abnormal that is happening in our body and how we will rectify them. That is what we will learn later. Am I right?
Yes, sir.
Yes.
So you have to, last time we learned about the normal, now we will learn about the abnormal. What is the abnormal aspect? What are the changes that is taking place in our body, in our mind? That way we are becoming addicted, and why a person who becomes addicted is not able to quit, right? And what we need to do to help him quit, right? So this neurobiology is see, once we are talking about as this tobacco, this addiction, as this tobacco, the nicotine as a disease, what is happening? There is something happening in the brain. Okay? And then there are receptors throughout in our body, nicotine receptors in our body. So these receptors, how they are getting wired, how they are activated, what is happening. So what is the pathology? Let's go ahead and understand that, right? So if we understand this, because this is going to be a very important thing for you, right? If we understand that, we will know how to approach a patient. And this understanding is the basic reason why most of the people who have not learned about it, they are not able to help a person to get rid of his tobacco. So this topic is very important. Please concentrate and learn about it in details. Thank you, ma'am. Reena, ma'am.
Thank you so much, Dr. Pawan. Thank you so much for setting the stage and the context here. So as Dr. Pawan said, what we are going to be learning out of this, he simplified it and put it for all of us to understand what really happens, what is happening in the brain networking. So what is the dopaminergic system and what is the non-dopaminergic system involved in the nicotine addiction and withdrawal? As he said rightly, that there are only two sides of the coin, one when the product is there and the other when the product is not there. So how does the brain react and how does the body react? Understanding how nicotine reinforces the behavioral change in addiction. Why this is important, as he rightly said to you just now, that because tomorrow when you're going to learn how to get this person out of the quitting habit, how do you get to quit this tobacco disease, what is going to happen? There's a behavioral change which has to have brought out. But how will you bring that about unless you know what really this nicotine is doing, how it reinforces this behavioral change and how it brings about addiction? And then, of course, the role of enzymes which are responsible, so because there is a body system which works there. So that is how there's a tolerance which comes about and how slowly there's a dependence. This is a little picture. Just look at the picture. It's a nice picture. I look better on the picture than here. Okay. So from there, when we go on, we come here. So what we are doing today is to understand the neurobiology of nicotine addiction. So when we say nicotine, so there are some words that you have to understand. Hedonic. Hedonic means pleasure seeking. So when you're looking at hedonistic, anything which you seek pleasure with, anything. So there are certain spots in our brain which are actually the hedonic hotspots. When we say hotspots, means these are the areas where the pleasure seeking zones are there, which is going to get super activated when we understand, oh, wearing a nice dress gives me that pleasure. Or, something when I eat this, it really gives me that pleasure. So similarly, tobacco or that substance, which is there we're talking about. So where are the hotspots which are there? So when you look at it, it's on the brainstem, is the ventral pallidum, is the orbitofrontal. Why do we say that? Because even seeing something, hearing something can act as a cue. So when you're seeing a friend, you see a tobacco shop, you see a packet of gutka, see something. So that itself can be a cue sometimes. A person, a place, a thing, a sound, a memory, anything can become a cue. So that is how there are these hotspots which are there, and of course the nucleus accumbens. So the addiction story starts somewhere along as hedonic hotspots which are there, and this is something which we are talking about is it's the hedonic homeostatic dysregulation which is going to happen. Sorry for that. Sorry. I just want to move these pictures. All these pictures are gathering so much space. Yeah, now we are okay. So I have kind of don't see anybody now because I just wanted the slides to be clean. So if anybody wants to speak, don't raise your hand. Just unmute yourself and speak. I'll stop. So you see this picture on the side is very nice. This little flow chart is very good because when you look at it, there is a tobacco product, right? And there is environmental influences. We have just talked about that also. The tobacco product, which is the product itself, and you have the environmental influences coming from different cues, which could be, your friend, it could be the role model in the home or the role model on the screen, that hero and things like that. So anything, it could be the role model, which is the environmental influences and the product itself, which will influence smoking behavior, right? Now, this smoking behavior, what happens? We look at the side arrows later on. It brings in nicotine. Why the smoking is here is because this is taken out of a journal. So in this Western journals, they mostly talk of smoking, but this would be the same for our smokeless tobacco or the chewing variety also. So you could just use it because I have not changed the words for the simple reason it's out of a journal. So smoking behavior, which brings in nicotine into the body. So when there is nicotine in the body, there are these little things on the side we will talk about. Nicotine in the body activates receptors. Dr. Pawan told us about receptors. These receptors are there in the brain. I have shown you the brain, but these receptors are there everywhere, from the skin to the lungs to the guts to the everywhere it is there. These receptors are there in the body, not just for the smokers, but for you and me and everybody, not just for tobacco users, but all of us. Now, what happens is what kind of receptors are these? Because they are basically acetylcholinergic receptors, but because they are sensitive to nicotine, so they're nicotinic acetylcholinergic receptors. There are different kinds, alpha and beta. There are certain number of alphas and certain number of betas. Some combinations of them really work towards the nicotine adaptation to nicotine, which causes what? As soon as this nicotinic acetylcholinergic receptors are activated, some channels open up. We'll talk about it. I'll show you the picture. Some channels open up and the neurotransmitter release happens. Once neurotransmitter releases happen, the brain now understands it. Oh, you see, there is going to be this particular thing now keeps me, whenever I have this particular product, I am able to not feel hungry. My appetite is suppressed. So this young girl feels that, oh, I can stay slim and trim. Oh, this person says my mood, which gets so irritable. Otherwise, I see my boss, I see my wife, I see whoever, and I am very happy when I have this. Or, my performance get better, the student. So all of this now starts getting reinforced inside the brain only because this is what is happening, this flow which is happening. Now, when you look at the side, this reinforcement is like a double barrel arrow. So it goes and it reinforces the smoking behavior. Because when I know that जब मुझे बहुत परेशानी होती है, I'm really very troubled because I have an exam tomorrow. And my friend told me, the last examination, he told me, "Arey, yaar, take this one fag or chew this one gutka. You see what happens. Nothing will happen. You'll feel so good." So my cognitive responses become very bright. I'm able to be really able to concentrate and I no longer feel scared. I'm like a hero that time and I'm able to study all night long. I don't feel sleepy. I don't feel hungry. I don't feel anything. So this gets reinforced. So the smoking behavior or the tobacco use behavior gets reinforced with all of this, which is enhanced performance, mood modulation. As I said, body weight is managed, withdrawal symptoms are managed. I was feeling whatever, and it becomes a way by which I self-medicate myself. So the addict is now modulating how much he has to take, when he has to take, how he has to take, what he has to take. And this becomes in his hands an addiction process. So that's why we like to say it's a suicidal agent. You know what you're doing, and yet you're going on swallowing it all the time, buying it and swallowing it, or using it in whichever way. Now, how does the nicotine in the body? Remember, Dr. Aruna talked about something about the way it is metabolized in the liver. Somebody can metabolize it faster, somebody can metabolize it slower. So the metabolism depends also on how much the nicotine is required by the body. Sometimes if the nicotine is being removed faster, but my dependence on it is so high, so as a result, I will need more of it because I'm metabolizing it faster. That's how my body is made. Like for women, there's a gender differentiation between male and females. And also there are certain enzymes which tells us who can metabolize it faster. There are certain enzymes which tell us, that, okay, this person might be able to be early initiator. So there is, that's why we said there's a genetic influence also, which is there. And there's a gene variance which happens because of which there's a huge metabolic way by which the nicotine dependence addiction has a play in that. What really can play on the nicotine on the body, nicotine acetylcholinergic receptors, all of this, the factors accepting this is age. So when you are younger, it's an experiment, it's an excitement. When you're a little older, it becomes a necessity. When you become, by the time, it's an addiction, and you are like completely, you're in all different ways. As last time also, it was touched upon by Dr. Aruna, that saying that there is a physical aspect to it, there is psychological aspect to it, and there's a social aspect to it. So what may start as a social goes on to become a psychological, and then is absolutely addiction. Is this clear? Most of the time it starts. That's why we brought in the school teacher. That's why we like to bring in, young people. We like to bring in influencers to talk about it, to make you understand how important it is for us to understand that it usually starts, rightly so, even the politically correct answer, but it usually starts as an experiment. So we don't say habit. It's an experiment. It's an excitement. It's doing something different. It's being in the, let's say in the niche group. It's doing something, my parents told me not to do it, so I must do it. So, or I'm very angry with my parents. They told me not to do it, so I must do it. So that's how it starts, as a rebellious behavior. And that's how the age, sex, as I said, there are other things about the women, and tobacco is what we'll talk about also at some time. Genetic predispositions, which we talked about, is a metabolism, and because the genes decide a large amount of things. Psychiatric disorders, because people who have, because we said that tobacco is the gateway for the drugs. So usually it starts with that and goes on to much higher drugs, and which is more emphasized currently with the new products like Juuls and things like that, wherein a lot of cannabis products are also added to it. Substance abuse, so it comes into that. So what is nicotine? All of you have read this side and all of you know it. It is a psychoactive. So because it makes it, it's a stimulant. It's a CNS stimulant. It's toxic and it's highly addictive. It is a product in the tobacco. So it is found in the tobacco leaves, in tobacco stem, in the tobacco roots, in tobacco, everything except for the tobacco seeds. So it spoils the environment, it spoils the soil, it spoils everything because it's a highly, highly addictive and a highly toxic. But it is a CNS stimulant. There's an interplay. Now, what happens? How does the addiction happen? Pharmacology, yes, because nicotine by itself is a stimulant. So there is a pharmacological part of it, which we are going to be studying about today. But it's a learned or conditioned, because the person knows, oh, exam kal hai. Last time मुझे जब इतना tension हुआ था, I took 2 cigarettes, or I did this, or oh, the night watchman thinks, I'm just feeling sleepy. Yesterday I had a celebration or I had a fight or whatever I had, and I'm feeling sleepy. Oh, the last time it was like that, I put some chewing tobacco in my mouth and I'm fit. So there's an interplay of learned conditional factors, genetic factors, social and environmental. We understand the social environmental, including the tobacco design, the product, how interesting it looks. So when a person goes to Goa on a holiday, you find them sitting on the beach because the environment is such. It's Goa. Well, Goa is Goa, they say. And it is, everybody is free from their work, free from their headache, and they've come here to enjoy. Enjoyment is associated with hookah. So it is about the tobacco product design, about the environment, about the way it is marketed. So all of this adds to the addiction process. So when we understand, that's why are we emphasizing on this? Because tomorrow when you're going to be doing managing the patient, you should know what are the information you have to get elicit from him without questioning, by conversation, taking this difficult conversation ahead to see, understand. He has to tell you, be able to tell you, I started as a child. This is the reason why I try. So you have to know, why did it start? Why did it continue? And why is he not able to let go? How many times has he tried? Why is he wanting to let go? So all of this is going to help you in the actually taking him through the quit journey, because you understand this person better now, and every person is different. So neuroadaptation develops. So how neuroadaptation develops? It develops because of these various things that will happen because of this neurotransmitters. So the transmitters are now transmitting out, these neurotransmitters are getting released. So the neural tissues and the structure brain is getting adapted. The whole body there are receptors, but we will stick to the brain for simplicity of understanding. And it goes on into a time where it becomes adaptation, tolerance, seeking more. So the drug seeking becomes much more and the drug taking is much more. And all this happens because there's a brain system behind it. Is this clear? Is this clear to everybody? I just need a yes or a no.
Yes, yes, ma'am.
Yes, ma'am.
Great. Thank you so much. Thank you so much. Because once we are clear on this, then understanding what are the neurotransmitters and what is it that is acting as such a great, let's say, attractive factor. So everybody wants happiness. So pleasure, appetite suppression. All people want to be thin, whether it's young girls, whether it's young men going to office, where they want to wear the smart suits, the slim fitting suits, the narrow pants. So everybody wants to be awake all the time. Everybody wants to have great cognitive enhancement. Memory wants to be in a great mood, and of course wants that mera tension chala jaye. Now you see all of this is coming from nicotine. Now work backwards and see what really happens. Dopamine. These are the neurotransmitters. Look what it's doing. Norepinephrine, arousal, makes you awake, because that is what it is, no? Flight and fright. So it is. So which part of the brain is involved? The amygdala, which reminds you, oh, it's there. Acetylcholine, so arousal, cognitive enhancement. Glutamate, memory enhancement. Serotonin, mood modulation, appetite suppression. Beta endorphins, reduction of anxiety and tension. GABA is again reduction of anxiety and tension. So if you understand what is it that the person is seeking, so is he seeking pleasure? Is he seeking appetite suppression, which would be in young girls, women, a lot of young people. Most people are seeking reduction of anxiety and tension. Many are seeking mood modulation. Many want, the student class will want the memory enhancement, examination people. Cognitive is those, most of the people who are night shift workers, they want arousal. So if you know this, if you understand what is the patient seeking and where is it coming from, you know how addicting is that person now about. Okay, fine. Should we go to the next one? So now we're talking about the receptors. So let's just look at the receptor in the brain. Similar receptors are all over the body, the skin, the gut, every part of the body we have, whether it's the bladder, everywhere we have these receptors. So the reinforcing effect of nicotine are mediated by activation of neuronal, because they're in the neural tissue. So neuronal nicotinic acetylcholinergic receptors, where they're in the dopamine pathway in the mesoaccumbens. So it is what really is this? It is a non-selective channel. There is a cation channel is there. Several positively passed ions can pass through it. So now what happens is there are these, sorry, what's happening? Why is it jumping? Yeah. So look at these are the blue dots on sodium, there is calcium in the green dots, there is this ligand which is there, which comes in the ligand binding site. So the minute, now these are closed channels. The minute there's a binding, the channel opens up. The channel opens up and it gets activated, and the channel closes in again and it's desensitized and ready to get activated one more time again. So that is how the ability of the nicotine to activate the dopamine projections relies on the beta 2 containing. So there is alpha and beta component. The most common ones which we say is alpha 4, beta 2, nicotinic acetylcholinergic receptors. So it is beta 2 containing. So the receptors, acetylcholinergic receptors, which have the beta 2, 2 betas. So you see, so you have this 1, 2, 3, 4. In the next picture, you'll see it. So you see they have 2 betas. Wherever there are at least 2 betas, which is containing neurons which are where expresses glutinergic apamine. So that's what happens. So as a result, there is a huge amount. Now let's take a closer look, focus in onto the receptors and see what happens. So So as the ligand gated ion channel opening of the nicotine is the ion channel which opens up, and you have this The pole requires the binding of a chemical messenger. So the chemical messenger has to come in. This is a ligand. So several different terms, of course, but we use the word ligand, agonist, transmitter. So this word agonist is something again you'll need to know. So the nicotine acetylcholinate receptors play a key role. What happens is the membrane depolarization, electric depolarization will happen because converts the neurotransmitter binding. So as a result, there is going to be a channel opening up, and as soon as the channel opens up, it binds to the domains of the subunits of the alpha and it closes again. So this particular contains basically 5 units. It contains 5 units composed of 5 subunits, which would be some would be alpha and some would be beta. All right. And it is the beta one onto which and the alpha one, which you have the acetylcholine cholinergic, and then you have the beta one, which opens and plays a role in the GABA. Is it okay? It's an overview of it, basically a deeper understanding. We can go into it. Whoever is interested wants to understand the neurobiology even deeper, happy to take it in there. This is a rat brain. We're keeping a rat brain flat so that we are able to understand. The rat is the closest model that we have to the human brain. So when we go to the rat model, so we look at this rat brain. Now you see, you're going to be understanding what parts. Look at these channels which are running. So these are all your neurotransmitter channels. Look at the yellow ones, which are dopamine channels. Look at the blue, which is the glutamate channels, and look at the red, which is the GABA channel, right? Now what happens is when it comes into the brain and there's a ventral tegmental area which is right here, it acts like a gas tank. So see, what happens is this is like a gas tank. Why do we call it a gas tank? It's almost fueling every part. It's fueling every part of the brain. So it is going to the amygdala. It is going into the prefrontal cortex all the way up till there it goes. The nucleus raphe. There's nothing that it doesn't leave. There's a ventral pallidum which is involved in that. The nucleus raphe is involved in it. There is the hippocampus involved in it. There is the amygdala involved in it. There is the lateral habenula involved in it. There is every part of the body is of the hedonic hotspots. So these are the hedonic hotspots. Why? These neurotransmitters are feeding them what? Dopamine, glutamate, GABA. What are these things? All that you saw in that, the neurotransmitters, which causes all that what a person is seeking. Okay, is it all right? Why is the amygdala important here when we talk about it? Why is the prefrontal cortex important here? So let's just touch on these two parts. What is the amygdala? It is the ancient brain, the primitive brain, which reminds you of, every time you see a lion, you must run, not go and try to shake hands with it. You should get to know it's not your dog. It's a lion. It's a tiger in the forest. Run. If every time you see fire, you don't jump into it. So you kind of remember the incidents, what happened, you know what it is, and it kind of keeps that memory alive in you. So it reminds you, hey, every time this guy was there last time, this friend, you had a great time with him because both of you sat down on the, in a pub and you had hookah and you had beer and you had whatever. So it reminds you, oh, every time I cross this, and I feel it's important for me. This is the place where I can buy all that. Oh, this is very scary just now. So amygdala reminds you of the fear that I am very scared. So every time there's a scare, take that. My tension arises. Hey, man, don't worry. Go reach out for that cigarette. Amygdala. Because it goes to the prefrontal cortex, it makes your behavior change. So, an addict of tobacco, a tobacco user, changes the social pattern behavior, the social, psychological, occupational outcomes, behavior, the way they are actually interacting, the functions are all altered. All right. So these are hedonic hotspots. The ventral tegmental area is the gas tank we call, because this is where I'll show you an easier picture, which will give you how the dopamine pathway is coming in. Because most people, at the OCTC level, we would only stop at dopamine, but at the CTCS level, we would like you to know all the neurotransmitters and what really happens. So this person now, he starts wanting more, because what happens, the desensitization happens, and immediately there is really the neurotransmitter is again ready to be activated. So the product, there's a need for more. So the dependence is characterized by symptoms of tolerance and withdrawal. When he doesn't have it, he's going to get irritated, he's going to be scared, there's going to be mood modulation, the way he behaves, the way he thinks, the way he performs, everything is going to change. So he will go and seek it. So tolerance and dependence leads to addiction over a period of time as the body needs more and more of the product because these receptors will keep getting desensitized and more receptors will be ready saying, give me more, give me more. The demand is there. So we understood that. We understood the amygdala, and that is why the person craves. We understood the prefrontal cortex, behavioral change, why the importance of cognitive counseling, why the importance of various things that we'll have to work with the patient. Because once you understand where is everything going on, wow, it's a brain issue. It's a brain issue. It's a disease which is far, far, far more. Okay. So now we remember that metabolism part of it which had come in because how much a person demands, because why this slide come in is because we're talking of dependence and tolerance. So dependence and tolerance, because it again depends how much of nicotine is there in the body and how much is required by him. So the nicotine, if it is getting metabolized, where does it get metabolized? In the liver. By what? By two enzyme groups. So it is by this CYP2A6 and CYP2D6. So nicotine will get metabolized into cotinine and is excreted in the urine, correct? Now, there are candidate gene studies have shown smoking and polymorphism of genes to be there, which particularly with the CYP2A6 and CYP2D6. So there is a metabolism which happens in the liver, secreted out. But if the metabolism is normal, maybe his demand is more, but the metabolism is faster. Like women are supposed to metabolize faster. So as a result, women seek more. The dependence is much more. And as a result, the quit process is sometimes tougher for women than for male. So there's a gender dimorphism here. There is monoamine oxidase. So monoamine oxidase are enzymes located in this system where other neurons catalyze and the metabolism of the dopamine. Or you see, at the end of it all, whatever is going to work towards is neurotransmitters, and that is what is going to be flushing it. So, and how much is it going to be metabolized out of the body is again which is going to decide how much is going to be the demand. How much is his environmental influences there, and how much is his own ability to inability to manage stressful situations. How he actually sees situations, how he is able to control. So levels of nicotine in the body in relation to a particular level of nicotine intake from smoking, again, as I again reiterate on this slide, is about the nicotine metabolism, right? So that metabolism part where Dr. Aruna had kind of overviewed it. Here I'm bringing it in the form of your neurobiology because you have to understand how that is also affecting your need and the demand for more nicotine. So the person, how he's going to demand more and why he's going to get more and more dependent on it. The question which Dr. Pawan put for us, is it a habit or is it a disease? So nowhere, never will we say it's a habit. It was never a habit. It was an experiment. It was an experiment, but it is definitely a disorder. It has been recorded in the DSM-5, and there are three criteria. There should be three criteria they should fulfill. Use of tobacco products over a year and has resulted in at least two of the following sub-features. That he needs more and more of the product and he needs to consume it. Unsuccessful efforts to quit. Inordinate amount of time. He will go, take the car, drive 10 kilometers, 5 kilometers, 3 kilometers if he's staying somewhere out of town just to go and buy that product. So he will take some time, effort, everything to go and get the product. He'll crave for it. There'll be cravings. Failure to attend to his responsibilities and obligations. He's not going to be able to meet his deadlines at work. He is not going to be able to meet his personal, professional responsibilities, or his relationship issues are going to develop. Continued use despite adverse social and interpersonal consequences. The world over, there are banners. There are world over people are talking, but yet these guys will say to hell with it. It doesn't matter. I don't care. I'm deaf, dumb, blind. It doesn't matter. I know all rubbish talk they do. Social, occupational, recreational activities, they will forego. When they're sitting in a dinner, they will go out. If there's a puja happening, they'll say, no, I need to be out. I'll just go for a walk and come back. What is the great walk at that time? It is because they want to go and take a, indulge in their activity. They know that tobacco is a hazardous situation, but they know tobacco is a dangerous item to be used in hazardous because there's a fire there. Even in a petrol pump, even in trains, even in flights, they will try to do it. They just showed I think a boxer a few days ago. There was a viral video of this gentleman on a spice jet. He is taking it as a great pride to have lit a cigarette, and he's actually smoking it and blowing tobacco smoke in that. Continued use despite use of physical or psychological problems directly attributed. So as a result, let's not even once say that it is a habit. It is a disease. When we start, we don't start as a habit. We start as an experimentation. We start as a pressure. We start as a psychological inability at that point of time. So it could be a social or a psychological pressure. A social pressure is a child. A psychological pressure is usually these young adults and sometimes children who have got a problem of communication at home, problem of being bullying in the school and things like that. So those are the children who are on psychological pressures. But otherwise, most of the time, children is on social pressures. The young adults, 50-50, social and psychological, both. They're unable to cope with the stress of growing up. They're unable to cope with the stress of examination, unable to cope with the stress of work or not finding work, unable to cope with, various issues concerned with their life. So all of it. So it is definitely a disease. There is no two ways on that. So tobacco withdrawal. So just the way I said, this product is something, what happens is, it is hedonistic. So now what is hedonistic? When you are seeking that pleasure, you're running after it. And when you don't have that, there's a dysregulation which happens. So the person goes to all extents to get it. So when he doesn't, why does he run after all extent? He can always say, tomorrow morning I'll be driving that way, I'll go and buy it. No. I'm going to go now. I'll just take a quick break, 15 minutes. Even though he knows that one way is 15 minutes, it's actually 30 minutes plus give and take the traffic. So still he will do it. Why? Because it is a dysregulation now. It is something which has got dysregulated. So the person's body is now craving for the product. It's out. Maybe he's a fast metabolizer. Maybe he didn't have enough of the product with him, or maybe his demand is so much because it is getting deactivated faster. The neurons are getting, so there is a neuronal level, there is a metabolic level, and there is other influences, the tobacco product by itself. So when the individual makes an effort to stop the use of nicotine, the following withdrawal symptoms may occur. So you have the picture there. Please take a look. Exactly what he fears. He doesn't want a weight gain. He wants that, he's trying to have issues here. He's got, of course, the throat and these kind of things we know. So the symptoms spike in the first several days and gradually fade away 30 days. What are we using? This is another interesting part. We're trying to get rid of tobacco, but we are using a nicotine, but we use another drug. It's being used to lessen the symptoms for the withdrawal. So the withdrawal symptoms, how we use this, how the withdrawals come up, and this particular one. So please keep this in your photographic memory that it is a disorder. It is very well established in the DSM-5. It is very well there. That is how the tobacco withdrawal is also coming up. Okay, is this clear? Any questions? Any doubts? Any debates you need to have on this? That even though all 7 of you wrote D, I know that. But are we convinced it's a D now? We need to be convinced ourselves, because unless we are convinced it's a D, we are not going to be able to do our job as tobacco cessation specialists. So it is a D.
Yes,
Right? So cycle of nicotine addiction. So there's a little picture here. You can take a look at this picture. So what happens is, now this guy is driving past this tobacco shop where he has to buy his tobacco from. So there's a smoking queue, or there's a stress. There's a work-related stress. Oh my God, there's so much of work to be done and so many sales targets I have not met, A, B, C, D, E, F, G, H, and oh my God, I'm just miserable. So there's a queue. What happens is, amygdala says, and now craving. Hey, Vikram, don't worry, man. Last time this problem happened, remember? You could handle everything. First, handle yourself. So handling yourself requires the amygdala is telling you the cue and the craving, saying that please call for the cigarette. We'll take to cigarette or whatever is chewing tobacco. So there's a craving there, and he starts the smoking. The nicotine spikes, those little nicotinic acetylcholinergic receptors which you saw, they kind of get activated. So when they get activated, you get pleasure, stimulation, mood modulation, and there's release of dopamine and other neurotransmitters. So here we'll not talk of those. And what really happens is that neuroplasticity means what? Now there's a learned conditioning happening also at the same time. Now these activated receptors, as I showed you, minute this ion channel is open, cation channel is open. As soon as it's a ligand, it gets deactivated. And there can be an acute tolerance also which can develop. That is not enough, give me more. Or you have inactive, more and more inactive activators, reduction in the amount of nicotine. And when there's a reduction in the amount of nicotine, now what is happening is there's withdrawal symptoms. and there's a hedonic dysregulation happening. That means the pleasure is no longer there. Now it is withdrawal, irritation, anger, scare, whatever, everything, is happening. And there's a dysregulation which takes place. The person is again craving for it. All right. Is the cycle clear? So what happens is nicotine use is reinforced by conditioning. So why? Amygdala is there. So amygdala will keep reminding you. So that's why you should remember that why we took the diagram of the rat brain was because it is a flat section and it's very easy to see everything there, right there. So it is your ventral tegmental areas like a gas tank, fills out everything, goes to the amygdala. Amygdala is the cue, reminding you all the time of the cue. What changes your behavior is the prefrontal cortex and all this which is giving you all the other things. So whenever it is not there, your prefrontal cortex is going to now start changing everything. So what can be a cue? What can be a cue? Why did we say that even the frontoorbital centers are there? Because the taste, the smell of tobacco, even tobacco smoke burning, the packet opening, the sound of that, the mood, the situation, anything and everything can be a cue for a person. Okay? All right?
Yes, ma'am.
Sleeping, except Sudeep, everybody else sleeping.
Yes, ma'am.
Have I put everybody to sleep?
No.
It was supposed to be a neurotoxic but active, so you're the stimulant.
Madam, this activated to deactivated is not clear. The second
Okay.
second
Okay. So
circle.
we will take you back. We will take you back at the end of this. Let me go back to slides. I will go back and show you. So let's just finish the flow and then we'll go back there. So you remember that there is a center channel. Okay, let me not take you ahead because you're still there. So let me just take you back. Now you see the center channel which is there, correct? Yes?
Yes.
Here?
Yes, ma'am.
All right, this is a resting one where the channel is closed. So what is this channel? It's a cation channel. So what happens is now you see all these things, sodium, potassium, everything is floating around and you have these receptor areas where you need to have the ligand coming in, right? So now the channel will open as soon as there is a attachment here which happens. The channel opens, things pass and the channel closes. So channel closes means desensitizing. I'm ready again, waiting for all you guys. So who's the guy? Nicotine. Give me more. Give me more. Okay.
Yeah.
Right. Got it.
Yeah.
So it's a key player in the neuronal communication. Sorry, let me just read this out to you, which converts the neurotransmitter binding into membrane electric potential. So your electric potential of your membrane is getting changed. Depolarization is happening. As a result, it's ready again to say start afresh. And here again, let's start afresh. Okay. Right.
Yeah. Yeah.
So this is fine now?
Yeah.
All right. So now this is just a simple diagram again, just for reinforcement. Nothing really happens. So, okay, for all of us, this is who said anybody who even thinks or should not ever, ever, ever think that what we have the first time is a habit. No, it is always a casual meeting. It is something which happens, it's always a recreational way, a social setup. That's why the teacher was a very important example we used today to start the entire discussion today, was because a teacher can start that experiment, that recreational, that feeling of feeling, I'm not grown up yet. So if I take this particular product, I'll be as smart as Shah Rukh Khan. Sorry for taking any names. For whoever it is, for some film hero or heroine or some dude guy in my class. So this is what the teacher can also do. Be smart, do not start. And telling them, be fearful, be careful. So these are the various things. Save the youth. So this is what comes in, that we need to know that the casual user should not be made out of a student, out of a class child. So it starts there. A person starts losing control and starts having a goal-directed behavior because now he wants, he likes, he wants things. So because why is this happening? Because the pleasure-seeking zone has understood, hi, this thing makes me very happy. Chocolate makes me very happy. So when chocolate is not there, when I'm feeling sad, I need chocolate to eat. So here it is tobacco. So it's the same thing. What is happening is it's a much higher level of risk we are talking about. And so now there's a habit which has gone into it as a hedonic dysregulation, and it changes your reward system completely. The motivation becomes different. It's an aberrant motivation which is happening. And of course, the person starts now it's a learned behavior which happens. So the word which we are using as habit is actually not the word habit. It's a learned behavior. So as I said, tobacco addiction is a combination of psychological, the drug by itself, and most important, learned and environmental. So the learning is that I have learned previously. Amygdala plays a role in that, right? Emotional memories which are there, instrumental behaviors which are happening, and all of this becomes cue associated, drug seeking behavior because of the hedonic dysregulation. Is it understood?
Yes, ma'am.
So multiple memory systems are brought in, multiple files have been opened in the brain and kept in there. Oh, when you felt like this is what helped. When you felt like that is what helped. When you felt like this is what helped. When you were thirsty, you didn't reach for water, you reached for Coke. Sorry again, I'm taking a name. So, so multiple files have been kept in the brain, and all of this will actually cause this hedonic dysregulation. So, seeking a pleasure and going out of the way, running after things, getting this moving is all what is the addiction process. All right, it is right here. Again, I will go through this. That's a simplified picture. This one. So there's a craving, nicotine smoking. There's a spike, activated. So now it gets deactivated. Dr. Rajkumari, deactivation is clear.
Yes. Yeah, yeah.
Yeah. So now it is ready for, because it got inactive, so it wants more activation. So it will become activated now. And when it is here, what happens? The nicotine level is getting higher now, and is getting nicotine level is getting. So the withdrawal symptoms comes in, and again. So it's the same process which basically happens. And we come to this slide, which is now talking of dysregulation. We call it as a HDD, which is hedonistic homeostatic dysregulation. Why homeostatic? There's a body is always trying to put everything back in a level. So homeostasis, it's physiologic homeostasis is what is being brought about. So now I'm feeling really, really very upset. This patient is feeling very upset, or this person or this tobacco user is waiting for his school time gathering, his whatever alumni gathering of his school, where they all, and only those guys are coming. The guys they sit down together, and binge on things. So now he is anticipating. So there's a pre occupational anticipation which happens. You can start this thing anywhere. You can start the process anywhere. There's an anticipation which is happening, and he's going to go into binge intoxication. And when he doesn't get it, there's going to be a withdrawal. And then he goes again negative, again he's going to start. So you can start anywhere. So you can start at this level, and this cycle is going to just continue. And when there's a dysregulation, he's going to go out of his way, run around, behave badly. His entire mood tolerance is going to be changing. His mood modulation is going to change. He's going to have impaired social and occupational behaviors and functions. Everything. There's going to be negative effects happening. So when there is a use, abstinence, heavy use, you see what is happening. Now you see where there's early dependence, see what's going on here. Late dependence, and there's a neuroadaptive state which happens. So why all of this? Because all the neurotransmitters are involved in this. There is spiraling into addiction which happens. So the person just goes spiraling. It's like going down a rabbit hole. It's like a whirlpool. You just have no control over it because your brain is hijacked now by this particular. All the hedonic spots have understood and changed the behavior and changed the learning matter. All the files have got stored in the memory. The files are very nicely filed up and stored in the memory. So here we will stick only to the dopamine because this is a simplistic one which we show most of the, let's say the classrooms for the OCTC, or we show the classrooms for our marshals to understand it easily. So we say that when a person smokes, within 7 to 10 seconds, the smoke is reaching the brain. So the nicotine enters the brain. Nicotine stimulates the nicotine receptors, which are sitting in the ventral tegmental area. Immediately, there's a firing of the nicotine, and it goes to the nucleus accumbens, from where it goes straight into the prefrontal cortex. So you understand addiction, you understand behavior, you understand cues. But at your level, we have taken you into a deeper level and shown you all the entire all transmitters, how the all transmitters are fired, and what are the different hedonic spots which are all fired with this, and also about what is there in that. That is your acetylcholinergic receptors with the alpha and the betas. So the addiction cycle uses for pleasure, enhanced performance, mood regulations, we know that. Tolerance, physical dependence, abstinence produces withdrawal. Withdrawal will be self-medication, go on and mediate the symptoms. So he kind of takes that enough so that he's able to modulate what really is happening. Okay, he's able to modulate that. A few articles basically on the genetics. We'll have a better lecture on genetics, which will come from Dr. Rakesh Rawal. He will join us as a guest speaker on one of the days and give you an insight into genetics and what are the different roles. So I will skip this slide for time factor because I'd rather much that we spend more time on speaking to each other and understanding what we have understood and what we have really not got into it. So this is again slides which we will go much deeper into. And by chance, for some reason, if Dr. Rakesh is not able to come, I will conduct a session on genetics for you. So the take-home message would be, what would the take-home message be? Drug addiction. So here we're talking about why I'm bringing out the word drug and not keeping it with tobacco is because this is the mechanism. This hedonistic dysregulation is the mechanism for all drugs. So whether you say that, have I learned about tobacco or alcohol or about this thing? You have learned the mechanism. The drugs which you would use for the method that you would use, basic specific drugs which you would use for de-addiction process or for the quit process, that would be specific, probably some for alcohol and some here which are for nicotine. But the overall business, so you say, is your classroom only teaching you tobacco? Yes, we are using tobacco as the baseline, but what you are learning is also, this is what would happen if the person was using cannabis. This is what the person would happen if he was using the, even if it's a, what is that, smelling, the smell, what is a primer or something of the paint, or even that Vicks or anything they smell, or even if they're taking, simple things to most complex items, this is the way it is. So your classroom here at ICanCaRe has taken you to that level to understand the mechanism of hedonistic dysregulation in the body. Okay, hedonistic homeostatic dysregulation, because the homeostasis is brought in. The body tries to bring in the homeostasis from where? From the learned behavior which is there in the amygdala, and the behavioral changes will be brought about by the prefrontal cortex. Okay, so hedonic homeostatic dysregulation is what you've understood. Multiple motivational mechanisms you've understood. Negative reinforcement you've understood, because that is what happens when the person, now, there's a construct in this. So as a result, now excessive drug taking results in part via negative reinforcement. Means what? When the person is not getting that, is now the dysregulation is bad. So he's going to start seeking more and more of that, such that he gets the reward and stress. And the more he seeks, the more will be the negative, because the next time the withdrawal symptom will be much higher. What is happening? All of this is getting stamped deeper and stronger in the amygdala, ventral striatum. Everywhere it is getting very beautifully located, filed, and say, yes, this file has been used multiple times and this file works. This can be checked on every time. Every time there's a problem, pick up this checkbox. So specific neurochemical elements decrease in reward neurotransmitters, dopamine, but also result in brain stress system. So now this corticotropin releasing hormone, what happens? So when he doesn't take it, this particular hormone is getting released because there's a CRF coming out there. So CRF is called, so there's an increased stress. So the person assumes now there's a much more stress if I don't take this. So how the neurotransmitters play a role in making the addiction process stronger. So this is something you really need to understand this, because stress coping mechanism, unless the person has that built in, or we help him build that process in him, or we understand that as the biggest factor, we are not going to be able to, because every time there's a stress, every time there's some problem, there's going to be a CRF. And a CRF means there's going to be the amygdala is coming in saying, hi, don't worry, the stress, I know what to do. Don't you worry, I have it all in my files. So chronic exposure to self-administration of nicotine abuse results in increase of reward thresholds. Am I right in this sentence? Chronic exposure to self-administration, chronic, going on using more and more, self-administration, buy it, consume it, of nicotine abuse. It will not like to use the word use, it is abuse, results in increase in reward thresholds, correct? Because you will require more. Today I'm happy with 1, by afternoon I want 2, by tomorrow evening I want 3. So the reward threshold starts increasing. Similarly, as the reward threshold increases, the negative effects when the product is not there becomes much more, correct? So the anxiety-like thresholds responses also become much more. CRF is playing a huge role, and your amygdala is dancing, making you dance. And amygdala makes sure that this frontal cortex is right under it, and that's what. So combination of decreased reward system function and increased brainstem response. So see what is playing a role. What I think is reward and what I think is stress. What is playing a role together is what is now responsible for this hedonic homeostatic regulation. So if we teach the person how to manage stress, if we teach the person how to get rewards from different other activities, you're able to manage that person to get a better homeostasis through different mechanisms, not through tobacco. Is this okay? So you are kind of now controlling the drug seeking behavior and dependence. Is this last line getting clear to everybody?
Yes, ma'am.
Yes.
Okay, so it's a combination of a decreased reward system function. So that means, and an increased brainstem response. So how do you manage these two to get that equilibrium? What the amygdala is doing? Aha, come on, I'm going to give you the easiest file that I have. But no, so what have we got to do now? We have to come in and say, okay, to decrease the stress system, one, we're going to tell you about how to handle stress. You did that exercise last time. One of them was breathing in and breathing out. So some amount of those things, various other things which we'll be telling you in 7 days.
Meditation.
7 days, yes, exactly. We'll talk about that. And the other thing is about how do you manage your reward system?
Reward
So
system.
learn to get a different reward. Maybe take a run, maybe grow a garden, or maybe put a rose plant, see how it blooms. So your reward systems have to be changed in the person's mind, right? So addiction is a disease. Tobacco addiction is a disease. There is no two doubts on that. There is never a doubt in any of our brains, and it should not be, we should not leave a doubt like that in anybody's brain who we touch or whose lives we are coming across. Craving, compulsion, loss of control, continued use despite consequences, and chronic use. So, despite consequences, knowing if I'm standing in a train and I'm going to be smoking where I'm not allowed to be doing that, I might be behind bars. I'm in a petrol station. I might set fire to the whole station. I don't care a damn. What do I care? I need it. So that's how it is. I am willing to go that risk, and I'm willing to do anything. It doesn't matter. So addiction is a chronic, progressive disease. Progressive. Friends, please remember it is not going to remain the same. Hence, we say nip it early. Don't allow it to start. And if it starts, get rid of it as soon as possible. We don't say wait till 13 years, wait till 18 years, come back when you're older. I'm sure you'll understand it better. No, it's a progressive disease characterized by physical and psychological symptoms. All right. This is just a cartoon which you've done the nicotine addiction cycle. I don't want to go about it. So I think you all know what it is. It is a very nice one, I thought. So I kept it in here. This is an important slide. This is your lifeline because you have to understand how we have come into a standardized approach. Why it is standardized? Because there's a way you have to handle it. It's like a flow chart almost. It is personalized. Why is it personalized? Because each person, as I said, has a different history, different way of metabolizing, different cues, different way of handling, different reward pathways, different stress mechanisms. So the hedonistic dysregulation which is happening for each person is different. How we have to understand each person and how we have to balance what we are going to take care of is going to be pharmacotherapy, behavioral approach, how we are going to manage the, let me not look at this first, let me just tell you about the physical addiction, the social part, and the psychological component. So psychological component, how will you handle? You will require medication, you will require talking, you will require, cognitive behavioral counseling, you will require the changing in the behavior. So behavioral interventions with a 7D approach, pharmacotherapy, all the medications which are there. These patients are invariably going to have other associated diseases. We have pulmonologists, we have ENT people here, nobody knows it better. We have dental surgeons here, we all know what happens in the mouth. We have all of that. So you can manage the associated illnesses. And of course, along with that, these guys have got a very low immunity. So you have to boost up their immunity. So together, managing this on such that you keep the balance very correct is what the cessation protocol of ICanCaRe is with this digitized approach. So hence, today you're going to have a second session onto the app. We've been able to give, I think, almost everybody today, except unfortunately with Rajkumar, Dr. Rajkumar.
They also get registered.
Oh, it's sort of wonderful. So this is now what is very important because with this you'll be able to kind of how you're going to be able to track it because tracking the progress, managing the patient, able to see his previous history. So it's not like, oh, acha, yeah, he had one vesicle in his mouth some time ago or in his nose or, he had some lung infection earlier. No. In this case, what was the cue? It's all put in down here. Why it's important, how you're going to handle this. So all of this comes right in here. Is this kind of reached somewhere? Have we kind of made headway on this? For questions, Dr. Pawan is here, so I'll give it to Dr. Pawan to take it ahead.
Thank you, ma'am. So I have a very simple questions to each one of you, and I want you to answer that. Each one of you need to answer that. So what is the take home understanding? I'm not saying take home message, take home understanding from what Dr. Reena has just given her presentation. You know, see, it is important to understand the entire thing, but छोटे में एकदम क्या चीज आपको समझ में आया इसमें से? What did you understand from this? How does this addiction take place? What is actually happening from the beginning and the end? ठीक है ना? So like we had a teacher, we are saying that कि be smart, do not start. है सभी को बोल रहे हैं ना, be smart, do not start, do not start. So how does it? What does it mean? क्या होता है? अगर हम एक बार स्टार्ट कर लें, अगर मैं if we
Don't even start.
pardon me, Dr. Rajkumari?
Sir, I mean to say that once we started, it is like an addiction going on a vicious cycle, and it is very difficult to break this vicious cycle because you get trapped in it. There is a activation and
So
deactivation.
पहला, why will a child start?
Because of the environmental influences, because of the curiosity.
Okay, Dr. Visuja, क्या बोल रहे हैं? Because of the curiosity.
Because of the curiosity, if the child is starting off it, if he is a teenager, and because of the social
Peer pressure, social this thing, the Shah Rukh Khan comes and says that कि मेरे को तो वाह, मेरे को कितना मजा आ रहा है, ठीक है ना? So all those things, that things comes up, and then this person actually, out of curiosity, what will he do? He will experiment. Right? And then what happens? He will experiment. मैंने, anyone of you have ever tried experiment? एक बार, हैं? Why you all did not try? You had no curiosity.
Because of awareness.
Because of
Awareness.
awareness.
Don't tell me that. You have not been in the college and nobody has even pushed you into it. That has happened to all of us, I think. Really?
No, sir. No, sir.
कोई नहीं बोला, अरे बर्थडे पार्टीज में तो क्लास 12 के बाद में बर्थडे पार्टी जब होता है तब तो हुक्का तो वहां रखना जरूरी है. तुम लोग तो उसी ग्रुप में हो ना, जब हुक्का तो बहुत एक्सपोजर मिला होगा. एक बार हाँ रीना मैम.
No, I said everybody has a story. See, before you're scared to even open your mouth, let me tell you mine. I think all of you will be able to hear this then and talk and come out, because unless you come out with it, you'll not know. See, I had a best friend of mine. Her father used to work with Kisan, and I'm talking of 1976. 1976, I was in Delhi College. So her father was in Kisan, and he would go abroad always. So he would bring all kinds of goodies, which used to be chocolates. We would all get chocolates to eat once in a while. And one day, Surekha, that's her name, my friend, we are all 64 years of age today. She pushed me into, we had lockers in Government Dental College, we had lockers, which were on the main corridor. So she opened the locker and she said, get inside. So get inside the locker, head only goes in, only this much of the body goes in. And there she's got a lit cigarette, one long brown one. Take it. So I said, no, I don't want it. I see enough cigarettes. No, take it. So take it and see. This is different from what you'd have smelled your dad smoking. So she pushes it in my mouth. She pushes it. So you see, there is somebody forcing me in the corridor, in the college, in the open, in the daytime. And she pushed it in. And I till today remember that menthol smell, and I can understand that why people can't leave that menthol and why we have to get rid of menthol. Because that one time I coughed, it was terrible. I never used it again. But all of us have got some pressure or something because of some friends or birthday party as doctor. Because today your age is different. You all are all much younger, much younger. But if you come up with it, you will be able to understand and talk about your patients. Because that's why it's important to talk, not to say, no, I never did it.
See, the best way of changing your habit is what? If you want to change a habit, then what do you have to do?
Start it now.
So we need to understand why is it bad.
Understand तो ठीक है. Understand तो chocolate भी खाते हैं, वो तो कई लोग बोलते हैं bad habit है ना. Chocolate फिर भी खा लेते हैं. Right? So what do we do if we want to actually change the habit? Number one is, the most important is admit it. Right? Admit that this is a bad habit and I want to change. If you do not admit it, if you resist, or if you do not bring it out, then you cannot change, because that will, you will always try to justify that what you are doing is correct. When I admit that what I am doing is wrong, or what I believe that it is wrong. See, there are a lot of things which someone will believe it is wrong, someone will say that it is right. But what I believe is wrong, and if I admit that, okay, this is wrong and I want to bring a change, I want to change myself, then only that change will take place. Yeah. So by admitting that I have done something wrong, maybe that will help us in becoming more stronger to resist, or to at least bring that change in our behavior, right? So, but that was not the question that I was actually putting in. I little diverted myself because of coming up with this topic. So my simple thing is what Dr. Reena has just taught us. उसको बहुत simple way से कैसे समझना है और क्या समझाना है. What do we train and what do we talk to the patients? Simple way. So experimentation. Urvashi, why you did not take it again? And what did you feel when you took it first?
So first time I took it just because, everybody around surrounding was taking it.
I'm not asking that. I'm not asking why you took it. I'm asking how did you feel?
So it has what I thought is initially, if you don't like one, then they have flavors. Anyway, they are trying to attract you. So either something you are going to definitely get addicted to. You will want to have it again. But because I was knowing I did not.
Number one is experimentation, or maybe something like a force. You have been pushed into taking it. And
Yes,
then
sir.
what happens? There'll be two reactions to that. One reaction, what Dr. Reena had, ekdam irritated. It's what is bloody hell out of it? Get out of it.
Yes.
Number one is the pleasure. The second reaction is the pleasure. So there are two groups of people. One who will hate it and hate it forever in their life. And the second group is that who will have pleasure. I will not describe these two groups. Again, we have described these two groups. These two groups are two different types, two different things. The second group is generally the one who has got a loss of communication at home, loss of feeling loved by others. So they are actually a little bit of, have got a little different type of bringing up, right? So this second group who has this, who starts liking it, now what happens? Now, एक बार तो मजा आया, अगर मेरे को रसगुल्ला खाने में मजा आया तो मैं दूसरी बार तो लूंगा ना.
Yes, sir.
अगर पहली बार अगर करेला खाने में मजा नहीं आया तो मैं नहीं लूंगा सेकंड टाइम. ठीक है ना? See, this is our thought process. Now I have taken that. Now मेरे को अब मजा आ रहा है. ठीक है ना? Now I feel wonderful. अब क्या करूंगा? Now I am going to try it again. Now, how does this start? Actually, what Urvashi has said, it starts as a pleasure, right? It starts as a pleasure, and we start taking it whenever we are little low, whenever we find that there is a friend group, when we are getting. So what happens? That person will again take it. Now, what happens to the brain at that point of time? See, I'm just giving the practical thing what Dr. Reena has given. Okay, and then what happens to our brain at that point of time? The brain is activated. It starts, जो हमारे जो receptors हैं, क्या है receptor? What is the name of the receptor?
N-acetyl.
N-acetylcholine.
Nicotinic acetylcholine.
Nicotinic receptors. And there are various types. There are alpha 4, beta 2, N-acetylcholine. So these are the which is in the receptor. So now what happens is the nicotine starts, and the pleasure hormone starts coming out from our brain, and it starts activating our frontal lobe. We are feeling pleasure and we get, हम लोग को मजा आ रहा है. ठीक है? हम लोग मजा क्या कर लेने के लिए, क्या क्या करने के लिए मजा कर सकते हैं? How do we get pleasure? Those who are not taking, all of us, what do we do to get pleasure?
So
हमें भी तो मजा चाहिए यार. हमें वो खाली सिगरेट, तो या तो मैं तो सिगरेट लेना स्टार्ट करने वाला हूँ. मेरे को भी तो प्लेजर चाहिए. I also want pleasure in my life. I want to be happy in my life. So what do? I take cigarettes. है ना?
So do some activities which interest us.
Yes. So we should have started thinking, yeah, सही बोल रहे हैं Dr. Pawan. I should also start taking cigarette. मेरे को pleasure कैसे मिलेगा?
So we should indulge in different activities which you like. Like if you like dancing,
Your
just
patients, whatever is their hobbies,
in dancing,
Yes. So we will
distraction
whatever.
from the day.
You do different
also,
activities.
yeah. So we also have our pleasure by different activities. We love cooking. We love food. We will play something. We will dance. We will jump. We will play. We will read a book. We will listen to music, and that also secretes dopamine in our brain, and that's normal. That's the normal way of doing things, right? The abnormal way of doing things is getting instant pleasure by taking some medications, right? And there are various groups of medication. The cigarette is one of them, but there are various groups of heroin, ganja, all these things. They also affect in the same area. The alcohol and everything affects in the same area. But now what happens? Now I want pleasure. अगर मेरे को जो बोलते नहीं अगर अगर शेर को खून लग जाएगा तो वो क्या करे? बार बार खून मांगेगा ना? बोलते हैं ना ऐसा, है ना? हिंदी में कहावत है शेर को खून लग जाएगा तो बार बार शेर खून मांगेगा. So similarly, जैसे ही इसको सिगरेट एक्सपेरिमेंटेशन के साथ होता है तो अब क्या होता है उसकी रूटीन बन जाता है. Now it becomes and then the tolerance starts. The brain starts getting tolerated. अब उसमें मजा नहीं आ रहा. तो अब क्या होगा? He will start taking more and more and more. Right? Now from pleasure, now it becomes a need. Right? अब उसको नीड पे आ गया कि अब उसको चाहिए ही चाहिए. अब उसको चाहिए. अब नॉर्मल एक्टिविटी हर मिनट में कुछ भी एक्टिविटी करने उसको चाहिए. अब नेक्स्ट क्या होगा? व्हाट इज द नेक्स्ट स्टेज? नेक्स्ट स्टेज इज दैट फ्रॉम pleasure it has come to a need. Now what the next step comes, it becomes more and more toleration, and the person when he doesn't have tobacco it gives a withdrawal symptom. ठीक है. Now the body is so much adopted कि निकोटिन लेवल रहने से ही उतना ब्रेन काम कर रहा है. ब्रेन उसके बियॉन्ड काम ही नहीं कर पा रहा. तो बियॉन्ड जैसे निकोटिन खत्म होगा तो वो बंदा क्या होगा? उसका बॉडी विल start demanding and body will behave abnormally. Right? Now this particular brain has become adopted to have so much of nicotine in the brain. If there is a decrease in the brain, nicotine in the brain, this body will respond or react differently, which is what is called withdrawal. And now it has become a disease. ठीक है. So initially the person wants मजे मजे में. ठीक है. उसके बाद अपना काम करने के लिए चाहिए. तीसरा लेवल पे जब आता है उसको अब अपने बॉडी को मेंटेन करने के लिए चाहिए. उसको विड्रॉल सिम्टम्स को अवॉइड करने के लिए निकोटिन चाहिए.
Yes, sir.
ठीक है. कैन यू अंडरस्टैंड द how this journey has taken place? Right? Now this has become a disease. Now अब मेरे को जब when I have come to that stage when I cannot stay without nicotine, because if I stop nicotine I am going to have withdrawal symptoms.
Withdrawal symptoms.
That is the time. So first stages में जो हमारा जो first stage है जब हमारा जो young whatever whoever it is, if he started taking tobacco, अगर हमारे खाली pleasure के लिए ले रहा है, अगर हम उसको alternate देंगे, so what happens? What is the alternate that we give him? Yeah, we give him some alternate like playing, cycling, dancing, sport, some activities, that will also give him pleasure, right? ठीक है. So what happens is he will stop enjoying or he will stop taking the tobacco. So that is the intervention that time. The second stage में क्या हो गया? When there is a need or when there is a right. So here in the need or what we call it as mild moderate type of addiction. So what happens is now this person will be requiring behavioral therapy as well as pharmacotherapy, right? And when the person has come into that addiction level, when he is not able to quit because he's having withdrawal symptoms, right? That time he definitely needs medications and behavioral therapy. He would have a lot of other diseases, comorbid conditions, like he would have hypertension, he would have cardiac problems, he will have neurological problems, he would be having some oral submucosal fibrosis, he would have pre-malignant lesions, he will have so many other infertility, so many. So that also needs treatment. So that is the comorbidity management, right? But what is the most important? So this is the understanding that how the brain responds and how we need to take care of that person. ठीक है, समझ में आ गई?
Yes, sir.
What Dr. Reena has just given in very detailed way, ठीक है ना, उसका gist इतना है कि इसको आपको समझना है. These are, then there are so many hedonic this thing and so many other terms that we need to understand. ठीक है, all अगर सबको समझ में आई तो हाथ, right?
Yes, sir. Sir,
So
I just wanted to share. 2 days back only, I had a patient in hospital. Like he was saying he's able to urinate only when he has tobacco in his mouth. Nothing functions for him if he's not having tobacco. So he also knows the ill effects of tobacco. See, he only keeps in mouth, goes, does all the functions and then spit it back. This is the level of addiction. And but he's 78 years old. So he's like, what can I do now? I don't want to do anything.
He is not able to urinate without tobacco.
Tobacco in mouth. This is what he's saying.
If he has a tobacco in mouth, he can urinate.
He can urinate. Yes, sir.
And he's 78-year-old male or female?
Yes, male, sir.
Male.
Yes.
So uska, you know something called BHP? Benign hypertrophy of prostate?
Yes, sir.
ठीक है ना? So benign hypertrophy of prostate. Earlier there used to be a surgery. Nowadays we give some medications to actually open up the channel, right? So maybe this medication, this hormonal that is affecting him, it may be that. So, but that is not the reason why he has to take tobacco to urinate. उससे पहले वो लेता था कि नहीं लेता था?
So he used to have this habit since like 30, 35 years. So.
मुंह में डालेगा तो urination के लिए जाएगा.
Yes, sir. This is what you say.
So, but that is good, na? If he will not have to go to the washroom if it doesn't. He doesn't have to go to the washroom. ठीक है ना? So that will be great. Chalo, that is, see, these are all, you know, justifications for their continue to have the habit. So it is not the reason. So yes, similarly, like Urvashi said, might be this person will require some, there is an alpha-4 receptor blockade in this thing, kya kehte hain, in the prostate, that needs to be treated with some medications. Similarly, these patients who would be having hypertension, they need some medications for that. They would be requiring some medication for the leukoplakia that they will develop. So this is the comorbidity management. Some patients will require medications for constipation. They will have nutritional events they would require. The immunity is so low. Cough ke liye bhi unko medications chahiye hoga. And when they will quit, there will be increase in the cough, right? So these are the various things that, and we have to tell them, okay, don't worry. I am going to take care of your urination. We will make sure that you have your urination, but you don't take tobacco, right? So that is an approach.